All right, I want to go to page 174. 174. Page 174. Okay, so we're going to do, you remember from a couple weeks ago, the last time we had a class, we said that the next section will cover all the main cardiac disorders as far as drugs go, and that would be arrhythmias, hypertension, angina, and heart failure. So we'll start with arrhythmias, but before we get there, I had gone through this already, so we'll backtrack a second just to bring us up to speed. And we did talk about this before as we finished off the last class, and then we'll get into the different arrhythmias. Thanks. Everybody's partying out there, 7 in the morning. All right, so on page 174. And we went through the last time, and this is very widely reported, been many studies and so on, that the cardiac risk, as far as, the simple question you're asking is, what's the risk of various cardiac diseases when the patient comes to surgery? And which are, the highest risk, medium, lowest risk, whatever. So the clinical predictors of increased perioperative risk, first of all, an acute or recent MI, that's obviously somebody who will be very unstable, and that would be an issue. They also put unstable or severe angina. We'll talk a lot about that. So somebody with a recent, usually they say within 6 months. That's what they would mean by the word recent. Some authors say 3 months, but usually they run a 6-month time period. So somebody who's had an MI within the last 6 months would be considered a major risk. Decompensated heart failure, and as I mentioned 2 weeks ago, that's the number one risk, cardiac-wise. The most difficult patient to manage is somebody in heart failure that's not compensated well. Significant arrhythmias, they're fairly rare, but a high-grade AV block, symptomatic ventricular arrhythmias, SVT, and so on. We're going to talk about that today. Somebody with severe valvular disease, so those are the high-risk categories. Intermediate risk is somebody with mild angina, previous MI identified by history, but it isn't recent, it's in the past, and somebody who's got heart failure but they are compensated or they're under pretty decent control. Next page, 175, severe diabetic, long-standing diabetic, especially type 1, and then somebody with kidney disease. Some minor risk factors for cardiac disorders, elderly, geriatrics, abnormal EKG, a rhythm other than sinus, a low functional capacity, meaning the patient can't do much physically, walk flights of stairs, walk a distance, cut his lawn, or carry groceries, whatever. History of stroke, and uncontrolled systemic hypertension. And as I mentioned the last time, that's kind of weird, isn't it? You'd think somebody had a blood pressure that wasn't under good control, and they're coming to surgery, they'd certainly be listing it as higher than a minor risk factor. But the data shows it is a minor risk factor for reasons we'll talk about. Now, as far as the next page, 176, with the strategies you can use to reduce the risk, do they work or not? So cardiac risk reduction strategies and their effectiveness, and you can see putting somebody on perioperative beta blockers, the evidence for effectiveness is only for major vascular surgery. Other patients can actually be harmful, and we'll talk about that in great detail. Statins, yes, they can be effective, so putting persons on statins can help. Alpha-2 blockers, vasodilating drugs, moderate effectiveness, and nitroglycerin doesn't have. Diltiazem is cardizem, and that doesn't help. Sending him for cabbage, pre-op, there's conflicting results about the effectiveness and increased risk of complications. Well, I'd say it's pretty good increased risk of complications if you send somebody to heart surgery to get them ready to have their knee fixed or something. So, whatever. Moderate effectiveness in select patients. If somebody has 5-vessel disease, they're cardiac crippled, they can't really have any functional activity, then sure, it might help. PA catheters, conflicting results about effectiveness. There's a definite increased risk of complications from inserting them, and so nowadays they're kind of down the drain. CVPs, 12 leads, and TEE are not effective. As far as the anesthetic management goes, using epidural anesthesia instead of general is moderate effectiveness, and using keeping the patient's temperature normal is moderately effective as well. There was a Kaiser physician, anesthesiologist from Baldwin Park. They just published a major study this week in the Orthopedic Journal contrasting hip surgery. They've been having, and I'm getting off on a tangent here, they've been having a hip surgery big effort here at Kaiser because there was such a backlog of people having to have their hips done that they had, they made a special effort. They were doing them on Saturdays. People were coming in the evening, get them in, anything to get the backlog down. So he went and studied. He did 16,000 hip surgeries, which is a pretty big number. And he looked at what's best, general or regional. And without a doubt, far better was spinal. If you're going to have hip surgery and you're my age, then have somebody do a spinal on you was the outcome. All right, now, procedures. What are the risky procedures? Not just disease entities, but the next page, 177. If somebody's coming for these procedures, high risk, meaning there's a greater than 5% chance of some untoward event happening. That was major vascular surgery, which is always the top of anybody's list. Those patients are usually pretty ill. Emergency major operations and prolonged procedures with large fluid shifts or significant blood loss. In immediate risk, that means 1 to 5% chance of some untoward outcome, and then where patients having a carotid, endovascular, AAA repair, head and neck surgery, big belly and or thoracic surgeries, orthopedics, and prostate. Low risk procedures are superficial procedures, cataracts, breast surgery, and ambulatory procedures, the surgery center outpatient kind of thing. Less than 1% risk. So I think that's kind of where we left off the last time we were meeting. So let's move on. Let's talk about arrhythmias. So if you look on page 179. Now, right away, let me say a couple things. First of all, you've had all these drugs in all these situations. You're all ACLS, you're all PALS, you're all whatever, you know. And half of you are cardiac nurses besides in your real life. So you have a lot of experience with these antiarrhythmics. And there's no difference between under anesthesia or not. You know, whatever the indication is, this is the same indication that you're used to. So we can kind of blast through these drugs a little bit because, again, you are familiar with their use and indications and so on. But I do want to say a couple things to start out with, and that is, first of all, in general, don't write this down. in general, a drug that depresses the heart is going to be antiarrhythmic. Because after all, if you think about it, the way to treat an arrhythmia, which is too much electricity arising from somewhere in the heart that it's not supposed to, you have to suppress the cells that are triggering out of sequence, and the way to do that is to give a cardiac depressant drug. So in general, if you say a drug is cardiac depressant, then right off the top of your head you're going to say, I would suspect this drug is antiarrhythmic, and you're almost always right. So if you think about anesthesia, of course, propofol, etomidate, Sevo, Des, ISO, etc., everything we do is cardiac depressant. So in general, anesthesia, the process of anesthesia, the drugs that we use, would tend to be antiarrhythmic, and it is. And all the data shows, and they've done studies for decades, and they always come out similar. All the data shows that under anesthesia, people have less arrhythmias than they do when they're awake, because the heart is depressed and it has an antiarrhythmic effect and so on. A drug that stimulates the heart, the other way around, a beta agonist, for example, or a cardiac stimulant of some kind, tends to be arrhythmogenic. Now, they don't always produce arrhythmias. As a matter of fact, most of them don't. But if you stimulate the heart as a process with a drug, you would have a tendency to make it more susceptible to having arrhythmias. So, with that being said, I'll also mention that the treatment of arrhythmias with drugs is pretty lousy. It's not real successful. Yes, there's a million antiarrhythmic drugs available. There's some select uses for some of them, but in general, they're not tremendously successful. They have a lot of side effects. A lot of times what happens is you get rid of one arrhythmia and another one pops up. So you unmask some arrhythmia you didn't even know the patient was going to have. That can be a problem. So a lot of the antiarrhythmics at higher doses or in some doses can be actually arrhythmogenic in one part of the heart and antiarrhythmic in the other. So pharmacology to treat for chronic arrhythmias is not tremendously successful. We try it because we don't have any other choices. What's most successful, of course, is ablation therapy, and sending somebody to the electrophysiology lab, cardiac lab, and doing some sort of ablation is tremendously effective, and that's preferred for a lot of arrhythmias nowadays, where the drugs have been hit or miss. So if you can do that, that's good, but this is pharmacology, so we'll stick to drugs. Now the second thing to mention is this, and I'll go on my camera. Yeah. Let me turn this on. So this is page 179. Yeah, this heart. This is basic physiology. I'm not going to dwell on it, but I'm going to just point out a couple things because they're important to understand the classification of antiarrhythmic drugs. So here's a cutoff of the heart, a cutaway of the heart, and they're showing that, of course, electricity is generated in the SA node and then flows through the atria, through the AV node, down through the ventricles. And the action potential produced in the SA node is a little bit different shape than in the AV node. This one here, down in the ventricles, there's an action potential there. The ion that tends to leak, spontaneously leak, which makes the SA and the AV node fire or reach potential, is generally calcium. So calcium is leaking in the cell, the SA node. When it reaches threshold potential, then it fires and you have a heartbeat. That's basic physiology. Same is true in the AV node. everything below the atria, the ions that are leaking is sodium. So I'll mention that for the following reason. So let's look at below this under classification of antiarrhythmic drugs. And we classify in the United States anyways, antiarrhythmic drugs as class 1 through 4, and then we have other. Class 5 is just other and miscellaneous. All the rest of the world, they do 1 through 5. So the U.S. is always a little different. So it's not a big thing. So now, first of all, a class 1 antiarrhythmic is a drug that blocks sodium channels. So by definition, the classification of a class 1 antiarrhythmic drug is a drug that blocks sodium channels. Now, take a look at my little table here. See, class 1, depression of phase 0, blocks sodium channels. Now, they further subdivide the classes 1 into 1A, 1B, and 1C. We don't care. We're not going to learn all that. Cardiologists care. Electrophysiologists really care. We don't. All we need is class 1, blocking sodium channels, and that's it. What drugs are you talking about? Well, let's take a look. Some of the most famous antiarrhythmic drugs are quinidine, procainamide, disopyramide, which is Norpace, lidocaine, whatever, go down the list. Some of the prominent antiarrhythmic drugs work by blocking sodium channels, and they were called class 1 antiarrhythmics. What other drugs work by blocking sodium channels? Local anesthetics, that's it. So a lot of the pharmacology books say that it's a, quote, local anesthetic effect in the heart, because it's blocking sodium channels. They just use the same terminology. Now, going back to my diagram above, and I mentioned where sodium tends to cause the effect. If these block sodium channels, and sodium is causing action potentials in the ventricles, then class 1 antiarrhythmics are good for ventricular arrhythmias. Right? Remember my little thing here I said up the top. The calcium, I'll go back on the camera. Calcium is affecting the SA and the AV node, and sodium is generating the action potential in the ventricles, all through the conducting system, the His-Purkinje system, and throughout the ventricular muscle. So if you have a ventricular arrhythmia, you're going to want to give a drug that blocks sodium channels, and that would be a class 1 antiarrhythmic. See what I'm saying? Blocks sodium channels. Now, class 2 antiarrhythmics, this is my table on page 179, are beta blockers. So if a drug blocks beta receptors, that's of course going to be depressant in the heart, since beta receptors control your rate and your conduction velocity. So blocking beta blockers are antiarrhythmic by having class 2 effects. We'll talk about that. Class 3 antiarrhythmics are drugs that prolong repolarization. They make repolarization last longer. And what causes repolarization in a cell? You have a sodium goes in, that's depolarization, right? All right, what's next? How does it get back to normal? Sodium goes in, potassium comes out, right? So repolarization occurs because potassium leaves the cell. It's basic physiology, right? So drugs that affect repolarization, class 3 drugs, are drugs that block sodium channel. I'm sorry. I messed up the punchline. They block potassium channels. Oh, thanks, that's better. So class 3 drugs are agents that block potassium channels. And that, of course, the granddaddy of them is amiodarone. It's a class 3 antiarrhythmic. Now, let's look at an action potential. Kind of a standard looking one. This is the next page, 180. So here's repolarization here. Depolarization is when sodium goes in, repolarization, potassium comes out. If you make repolarization longer, the cell's going to be more refractory, and it's going to be an antiarrhythmic effect. In other words, when you're, trying to come up with drugs for arrhythmias, if you can make the repolarization last longer, you can't fire the cell while it's already fired. So when it's repolarizing, it's refractory to further arrhythmias. So if you can make the repolarization last longer, you can make it more antiarrhythmic. When I learned this, the instructor gave an example of somebody standing in the middle of the room and jumping up in the air, just jumping up and going back down. And their example was, well, if you're jumping up in the air and you're up here, you can't jump again until you get back down to the ground and feel the ground and then jump up again, right? Well, the same is true with this. You can't have another arrhythmia when you're still in the air. You're still repolarizing. You got to get back to normal or back to the threshold, and then you can fire again. So blocking potassium channels makes repolarization longer, and then that's it. Now, class 4 antiarrhythmics, the last one, at least in the United States, are calcium channel blockers. So if you're a class 4 antiarrhythmic, you block calcium channels. And what kind of arrhythmias do you think calcium channel blockers would be the most effective for? Atrial, exactly. SA, AV node, atrial muscle, atrial fib, atrial flutter, that kind of thing. Because if you block calcium channels, you're messing with the atria. Now, class 5 antiarrhythmics are miscellaneous or other. And look at, in the U.S., what they list in there is, first of all, adenosine. Adenosine is obviously a natural substance in the body, and but when you give it as a drug, it causes temporary cardiac arrest, and when the heart stops, then you're hoping that the regular electricity will sequence, go back to normal. We'll talk about adenosine a little bit. We don't use it in anesthesia. We tend not to want to give drugs to make the patient's heart stop in the middle of their hernia operation. So that's not one of our drugs, really. Digoxin, of course, is famously antiarrhythmic, not used much anymore for that use, but certainly has been around for hundreds of years for the treatment of atrial fib. And atropine, of course, can treat bradycardia, so that's listed as an antiarrhythmic as well. As I say, outside the U.S., they list these as class 5. In the U.S., we just say other. So that's the classification for the antiarrhythmic drugs. They try to make it so it's a little bit useful in your brain to know, well, if this one's blocking sodium channels, if a new drug comes out and it's a class 1 antiarrhythmic, then at least the medical person can say, well, it's probably going to be used for ventricular arrhythmias because that's what sodium channels do. If it's a new calcium antagonist, for example, they'll say, well, it's going to be for atrial arrhythmias or whatever. So it gives you some idea of its efficacy for various types of arrhythmias that can occur. Okay, again, I'll go back to page 180 in the little diagram here. And we don't have to go through it all, but the little write-up on the bottom says the classic 4 types of antiarrhythmic drugs. Class 1 agents affect sodium channels. Class 2 agents are beta blockers. I'm reading in the legend here. Class 3 agents block the outward potassium channels, prolong the action potential, and make it more refractory. And Class 4 agents, verapamil and diazinon, are calcium antagonists. Most antiarrhythmic drugs have more than one action. The action they describe here is just their primary effect. So Class 1 agents here in a little diagram. Let me get a pen. Sodium blockers, Class 2 agents, beta blockers, Class 3 agents, potassium blockers, Class 4 agents, calcium blockers. Okay, make sense? Now, what can cause arrhythmias under anesthesia? I would say the most common cause is light anesthesia. Patient gets light, they get a little tachycardic, and release some catecholamines, and the next thing you know, you can start throwing some arrhythmias. However, there's a lot of possible reasons, and here's on page 181, and here's the reference on the bottom. So they talk about general factors that can produce arrhythmias under anesthesia, advanced age, elderly, atrial enlargement, heightened adrenergic state, somebody's scared, drug toxicity, it could be a drug effect, hypoxia, hypovolemic, and hemodynamic instability. Reperfusion can cause it. For example, in severe hypertension, hypoglycemia, pulmonary disease, and beta blocker withdrawal. Structural heart disease, all kinds of cardiac disease, and they list about every one of them there. And then transient imbalances. If your electrolyte is out of whack, you have a metabolic imbalance of some kind, acidosis, alkalosis, laryngoscopy, hypoxia, and hypercarbia, stimulation from you digging around down there trying to find a hole, stick a tube in. Device malfunctions and microshocks can occur from pacemakers or Bovie machines or whatever. Surgical stimulation and central venous catheters can be tickling something in the heart if they're in and produce arrhythmias for that. So those are the kind of anesthesia-related issues for the cause of arrhythmias. The next thing I have is a little something about atrial fib, and I want to just take a second and mention. In fact, I was just reading, somebody sent me something yesterday, and they said the average population walking around, about 10% of the people with arrhythmias have atrial fib. It's usually considered one of the most common of all arrhythmias. And the Apple Watch, I don't know, some of you may be wearing one right now, they've got a little thing that comes with it that you wrap around your wrist. That's an EKG machine nowadays. They just came out with it. And you can measure, put your Apple Watch and set it, and it will tell you when you're in atrial fib. So patients who have that issue, which is a lot of people, literally millions of people in the U.S., can now determine for themselves that they've gone into atrial fib by looking at their Apple Watch. So, times are changing. I thought it was kind of cool. I'm not sure what you just took punch yourself in the chest, or drive to the hospital. I'm not sure what you. At least you know you got it right there in your watch. So atrial fib is an issue, and of course we'll talk about it under anesthesia, how to deal with some of this stuff as well. We'll come back to that. Now, let's go to, before we get into all this mess, let's go to page 189. I don't have a page listed as 189, excuse me, I just noticed. It's this page here. Drugs for cardiac arrhythmias. Go to page 190 and then go back one. Now, we'll try to make this as simple as possible. It is simple. This is all information you already know. So let's just kind of briefly go through this. This is a medical letter, and I think it's an old one, 2007. Things haven't changed. They usually push a new one out unless something's changed. And so this is how you treat the drugs of choice for the various arrhythmias, and then we'll talk about anesthesia. So if you look at this, the next page, under atrial fib and SVT, the treatment for atrial fib or atrial flutter is to use rate control, see what they're saying, IV verapamil, diltiazem, or a beta blocker, if possible, or cardioversion, etc. So, first of all, if somebody has atrial fib or atrial flutter, they may it may not be a good idea to get them out of it. In other words, if somebody's in chronic atrial fib, but they're otherwise okay, then they may stay in chronic atrial fib. So some cardiology folks can mess with that. What you want to do is check their pulse and see what their ventricular rate is, how much their rate is compared to the fibrillation that's going on in the atria. How many of those aberrant beats that are floating around the atria all the time are making it through the AV node down into the ventricles and causing contraction. And there's controversy about everything in cardiology. This controversy tends to be, should you use loose or strict rate control? There are cardiologists and studies to back them up that state that as long as the heart rate is below 125, blood pressure is normal, then that's fine. There's other people that go for strict rate control, meaning that they want the heart rate to be below 110. Patients will do better that way, so you can go either way. The big thing for us is if you have a patient that has atrial fib under anesthesia, you want them to have a good blood pressure. So if they have a heart rate of 115 and the ventricular rate is pretty well controlled, it's fairly, not too erratic, the blood pressure is good, then that's fine. Take them to PACU and get 90 cardiologists to come down, stand around outside their bed and figure out what to do, because we certainly don't know how to do it. So, what they're saying here in the table, atrial fib or flutter, the acute management is you want to keep the patient's rate under control. Everybody know what I mean by rate control? Right? You don't want the heart rate to be 140 ventricular. You want it to be semi-normal and slow as you can get it, 110 or less. The drug to do that, as you can see, because it's a atrial arrhythmia, are the calcium channel blockers. So they're listing here. The drugs of choice are verapamil and diltiazem. So verapamil or cardizem. Now they also mention you can give a beta blocker if those aren't one of the choices, if they're not available. If you more prefer to use a beta blocker, that would be fine too. Either one. So you want to give one of those three types of drugs. Now they also mention cardioversion, etc., but that's something that's going to be done in the unit. It's not done in the middle of an operation. So that's later on. They also mention digin here, and digitalis is not useful to us. We're not going to be digitalizing people. It takes up to 24 hours for it to work, so what good does it do to us? Nothing. We're going to learn about DIG and what do you do with a patient who's on DIG that comes to surgery, but it's not going to be a drug that we give. We just see people on it and we manage it from there. We'll talk about that later. Okay, so that's atrial arrhythmias. Now a little bit below, if you, for chronic treatment, and they'll mention the drugs and all that, but that really doesn't involve us. But it is similar, beta blocker, calcium blocker, etc. For other SVT supraventricular arrhythmias, the acute management, if somebody has SVT, all the various forms, or any of the various forms, the drugs of choice for acute treatment is, of course, adenosine, but that's not available for us. We don't give it. It's too dangerous to give in the middle of surgery. So we use calcium channel blockers, verapamil or diltiazem. Again, same thing. You'll see them listed here under SVTs, acute management. Now, if all else fails or you're not comfortable with that, you can, again, use the beta blocker. So you look under alternatives, IV esmolol or other beta blockers to help with termination of the arrhythmia. Now, you're not going to terminate the arrhythmia unless the pathway for the SVT goes through the AV node. Many of them have pathways that don't involve the AV node as they have the supraventricular tachycardia. And if it doesn't, then these drugs aren't going to be effective. That's what adenosine lets you know. Nonetheless, that's the treatment. Now, long-term suppression, again, listed beta blockers, calcium blockers, and some of the oral agents. Okay, the next page, PVCs, that's easy. Anything with the word ventricular in it. One answer is what? Which drug would you use for a ventricular arrhythmia? Amiodarone, right? You can use lidocaine. It's not listed as preferred by the American Heart Association anymore for, ACLS and all that. But we're more comfortable with it and it'll work fine for us. So you can see the PVCs, if they become so frequent that they're symptomatic, the patient's having a hard time maintaining a blood pressure, then you want to give some treatment. You can give some IV lidocaine, IV amiodarone. They list here SVT and ventricular fibrillation. Well, then you're in a resuscitation situation. But nonetheless, the treatment for ventricular is amiodarone. So atrial is calcium blockers. Ventricular is amiodarone. Makes it pretty easy, right? Anything to do with DIG, a DIG-induced arrhythmia. So they're listing here the next one down, cardiac glycoside-induced ventricular arrhythmia. Somebody's on DIG, they're DIG toxic. They need to be treated. You just treat it like it was a regular arrhythmia. You don't have to worry about the DIG caused it. You just treat it. We'll talk about that later. And lastly, torsades. The treatment is IV magnesium. So there we go. That was easy. Atrial, you're going to give verapamil or diltiazem. The alternative is a beta blocker. Ventricular, you use amiodarone. Alternative is lidocaine. For torsades, you're going to give IV magnesium. For bradycardia, you treat it, you all know this, using atropine. And for severe tachycardia, you're going to use a beta blocker. Esmolol, labetalol, we'll talk about that later. So, that's it. We'll keep it pretty simple. There's a lot of antiarrhythmic drugs out there, but they're given orally, or they're given IV, and they have to have 12 lead EKGs, and you have to be monitored in a cardiac unit, and all kinds of stuff that goes on that we're not able to do. And as I mentioned in the chapter, and I'll say it here, it is common sense to realize that it's hard to treat an arrhythmia when you just have a 3-lead EKG on, which we do most, for the most part, 100% of the time, in the middle of an operation with somebody's belly wide open, and then you're going to diagnose and treat some fancy arrhythmia? I don't think so. But what we need to do is just keep the patient stable, get them off the table in the PACU, and get somebody in there that knows how to deal with whatever it is to deal with, some cardiology folks. So our goal, when we deal with this, is a little bit different than, but chronic therapy or a nurse practitioner, or cardiologist, whatever, that's trying to deal with arrhythmia. We want to treat it acutely, just to make sure it doesn't progress, it doesn't cause something more severe to happen, and that the patient has stable vital signs. And we can do it that way. Now, let's go back and I want to mark the page here. I want to go to page Now, let's take a break. I can find my page. It's time. All right, let's get started again. So to reiterate from prior to the break, I mentioned that for atrial arrhythmias under anesthesia, we're going to use calcium blockers, either verapamil, diltiazem. Ventricular arrhythmias, either lidocaine or amiodarone. For bradycardia, atropine, tachycardia, probably esmolol, severe tachycardia. And then torsades is the IV magnesium. So those are the standard treatments for the arrhythmias we're going to run into. Now, when somebody's asleep, obviously in the middle of the case, they have a lot of anesthetic drugs on board, the gases, potentially IV drugs as well. And so the doses they list for the various antiarrhythmics, you always have to take them with a grain of salt under anesthesia, because that's always superimposed on top of the drugs that we're giving. So I guess it's a long way to say give less. Let's cut the dose down under anesthesia. You can always give more, you can't take it back. So start with whatever they recommend the dose. Usually you can start with about half of that, see if that helps you out. If somebody has an atrial arrhythmia, atrial fib, flutter, SVT, then you give the standard treatment, a small dose of verapamil or diltiazem. And if you want to look at page 186, I've listed the drugs out for you. And what class they're from, the doses, a little bit of comment about each of them, and so on. Now, if you, just in general, if you have a patient that goes into atrial fib or atrial flutter during the case, then it's certainly justified in trying to reverse it and go back to sinus rhythm. If you have a patient who is in one of those arrhythmias chronically, comes to surgery and they're going to be in that arrhythmia when they leave surgery, then you don't need to treat it or want to treat it. In fact, unless it's been a recent arrhythmia, you have to heparinize or anticoagulate those patients so they don't throw clots when you get them back to normal sinus rhythm. So there's a whole procedure for dealing with that, which is going to take a cardiac unit and concerted effort by a number of people. So you really don't want to convert those unless you've witnessed them going into it. You know that it's recent occurrence. For the So there they list adenosine and so on. So let me, page 186, the first one they mention is adenosine. So I just want to take a second and talk about it just for the definitions. Like I said, we're not going to really use it during surgery of any kind, but just so you're complete, look on page 184. 2 pages previously, 184. Now, adenosine is one of the natural chemicals in the body. It makes up ATP and adenosine monophosphate, it's diphosphate, and so on. It's a purine, referred to as a purine in the body. And when you use it as a drug, it's taken out very rapidly into the cells and then metabolized. So the duration of action is going to be measured in seconds. And in fact, for those who've used it, you know that you try to give it in a central line as close to the heart as possible so it gets there without being metabolized first. Some people give it and then flush it with saline right afterwards to flush it up towards the heart through the IV, just so that it has time to work. And if it gets to the heart, it'll cause cardiac arrest. So it stops the SA and the AV node. The idea being that then the heart aberrant pathway stops and the normal pathways can take back over again. So the patient can then, or they go into arrest, and then after so many seconds, they'll start to have normal, regular heartbeats, as if. It doesn't always work. It works sometimes and sometimes it doesn't. But nonetheless, we're not going to give drugs causing cardiac arrest during surgery. So that's something that we're not going to do. But if you look on page 184, I just want to mention that these receptors that it works on are called purinergic receptors. Purinergic receptors. And there's 2 types, P1 and P2. And there's some differentiation in their function and so on, which we don't really have to care about, other than the fact that adenosine, this is a question I'm going to ask you in a test. Adenosine works on what kind of receptor? And your answer is going to be a purine receptor, purinergic receptor. If you stimulate a purinergic receptor, for example, look at P1, A1 subtype, you get slowing of the SA and the AV node, bronchoconstriction, that's not good, dilation of the cerebral and coronary vessels, and changes in neurotransmitter release. So adenosine's antiarrhythmic effect comes from the fact that it interrupts conduction in the SA and the AV node, producing cardiac arrest, and that's how it works, via purine receptors. Okay, next, back to page 186 in the table. The next one listed there is esmolol, and I'm going to talk quite a bit about esmolol and labetalol later on, but I'll give you just in general. Esmolol is usually, for anesthesia, used to treat tachyarrhythmias. Esmolol is used to treat tachycardia. Labetalol is more used to treat hypertension, for reasons we'll talk about. So if you have if somebody's tachycardic, they're 130, the first thing you're going to do, of course, is explore why are they tachycardic at 130. Are they dry? Do they have a fever? Do they have an imbalance, electrolyte imbalance? Is there some other sepsis? Is there some process going on causing tachycardia? If you can't figure out what it is and you want to slow the heart rate down, most people would recommend you use esmolol as the anti-tachycardia agent. Now, there's always 3 categories of patients that you want to be careful giving a beta blocker to. So I'm just being generic here. And if you're going to give a beta blocker to a patient, which we do a lot, We use a lot of esmolol, a lot of labetalol, they're good drugs. But you always have to ask yourself three groups of patients. All right, some don't really relate to anesthesia, but whatever. These are the three types of patients you don't want to give a beta blocker to. Number one is asthmatic, because obviously the beta blockers cause bronchoconstriction. If you block beta 2 receptors in the lungs, you get bronchoconstriction. So you don't want to give beta blockers to asthmatics. You can make them worse. Now, esmolol is listed as being somewhat cardioselective, and I'll talk about that here in a minute. But it's not when you give it IV. So don't worry, it's going to cause bronchoconstriction. The second category of patients that you don't want to give beta blockers to are people with diabetes, because hyperglycemia is a beta effect in the body. If you give a beta blocker, it produces hypoglycemia. And you don't want to drop somebody's blood sugar or mess with it if they're diabetic. So be careful giving. The third category is people with claudication and difficulty walking. Well, that's not really related to anesthesia. Our patients aren't walking around the OR. But the two categories we do deal with, of course, are diabetics and asthmatics. So be careful using them. If you have to give a drug to a diabetic or asthmatic, you're better off giving a calcium blocker, because they don't produce bronchoconstriction and they don't produce changes in blood sugar. And speaking of them, the next one down on page 186 is verapamil. And they say the normal dose is 5 to 10 milligrams IV push. And I would say the normal dose for us should be about 2.5 milligrams to start. Give it slow, wait 4 or 5 minutes, see if it worked. You can always increment some more of it in. The next page, diazem is listed there, and that's available IV as well, cardizem. And they talk dosing and so on. You can take a look at that. Now, one last generic kind of statement is, if a drug speeds conduction velocity in the heart, in other words, it's a beta agonist, then it would tend to be beneficial in somebody who has a heart block. Remember, a heart block is just somebody has slower conduction in their AV node. First degree, second degree, complete, whatever. It means a slowing conduction in the AV node. If you can speed conduction in the heart, a beta 1 effect, then you can have a beneficial action towards the heart block. So you treat a heart block, generally you give atropine, because it speeds conduction through the heart, and somebody's doing the dishes, I don't know. Henry, can you hear that?
Yeah, it's only just you. I'm just going to drop them.
All right, thanks. To hear that. He just means sound, he doesn't mean picture. They're dropping their sound to us, I mean. So, if a drug slows AV conduction, it can produce a heart block. So, I just mentioned that because one of the contraindications to calcium blockers, diazem, verapamil, whatever, one of the contraindications to beta blockers, esmolol, labetalol, metoprolol, or whatever, we're going to get into them in great detail here in a few minutes, is somebody with a heart block. Because they all slow AV conduction. Calcium blockers do, beta blockers do. If somebody has a heart block, it's going to make them worse. That's just generic. If a drug slows AV conduction, it's going to be contraindicated in heart block, because that's what heart block is, a slow AV conduction, right? You don't want to make it worse. Now, here's a trick you get a lot. some people ask if it's your preceptors in the OR, the CERT exam or whatever, and that is, you probably work with people that are in the habit of using lidocaine during induction pretty routinely, and they do it to suppress cough, make the patient more compliant for intubation, and so on. And it works, and it's fine to do. I have no issue with it one way or the other. However, if you do it on a routine basis, lidocaine is going to produce a heart block because it slows AV conduction. So it's somebody with a heart block that you're giving 80 milligrams or 60 milligrams of lidocaine for induction, and you do it on a routine basis and forget that the patient had a heart block, then you can sometimes make it worse. Give them a complete heart block during induction. So all I'm saying is, it's fine to do whatever it is people like to do, but just don't do things routinely on every patient without thinking, maybe this patient has a heart block, maybe I shouldn't use lidocaine on this patient. Question?
Is that transient or is it?
Transient, yes. It lasts around 15 to 20 minutes, which is what a single dose of lidocaine IV push lasts around 15, 20 minutes. If you're going to use it at the end of the case, same thing. Some people use lidocaine at the end when they're in extubate people to bring them up, make it more smooth, etc. And again, that's fine to do. I have no problem with it. It works. However, it can make heart blocks worse, and the duration is around 15, 20 minutes. Okay. Now, I want to go to page 196. And since I love to repeat myself, we're going to repeat. Drugs used for post-op or arrhythmias. This is from an article. I put the reference on the bottom. Peri-op cardiac issues, arrhythmias, and they're listing some of these same drugs we talked about for the treatment of whatever arrhythmia you might run into in the recovery room, etc. And there's adenosine, atropine, diazepam, esmolol, metoprolol is good for rate control, beta blocker, and then of course inhaler. So there's the standard drugs and what you want to watch for and so on. Okay, anybody have any questions on that? All right, we'll come back to that then at a later time, but what I want to do now is go to 197 and let's talk about hypertension. I'm going to talk a lot about it for the next 2 to 3 classes, and then we'll come back and mention arrhythmias too. Hypertension. Everybody's hypertensive nowadays. Half the population has now been classified as hypertensive. And what they're looking at, this page 187, this I took from an article in Current Opinion in Pharmacology, and they're just looking at the different type of antihypertensive drugs, potential sites of antihypertension drug action, page 197. Drugs can work in the CNS, in the heart, in blood vessels, or in the kidneys. They're the primary sites where antihypertensive drugs work. And so we're going to get into all that. Let's go to the next page and stop and let me talk. Okay, don't write anything down. Here's what happens. Hypertension, of course, is very common. In fact, by recent I mean this month, reclassification of hypertension has made it so that probably 70 to 80 million of the American population is now classified as hypertensive. There's some controversy about that, but nonetheless it is. Now, here's what happens. First of all, you're going to see as we do this, we're going to go through probably 100 different drugs. And the reason why there's so many different ones is because hypertension is such a multifaceted disorder. Hypertension is the symptom, high blood pressure. The cause, the etiology of that problem can be whatever. I can take 10 patients, line them up in a row. They all got a blood pressure of, I'll just make this up, 180 over 110, so we call them hypertensive. But patient number 1 has kidney disease. Patient number 2 has a heart problem. Patient number 3 is a CNS problem. You get the point. Patient number 4 is a hormonal problem. Whatever. So they all got a different disease, but we just call them hypertensive. And that's why it's hard to come up with one drug alone that treats, quote, hypertension. Because hypertension is such a different disease from patient to patient. So what works very well in one patient may not do anything in the next patient. You've all had that experience. You work in units. You try to chase people's blood pressure before. The drug you used yesterday that worked well, you try it on your patient today and it doesn't do anything. And you say, hey, what's going on here? Well, it's because they had a different problem causing their hypertension. So that's first of all. Now second of all, is the classification. So what happened way back in the 1950s, I think, the feds decided to pull together some groups and try to come up with a national consensus to make sense of this. How can we approach the, quote, disease, hypertension, in a rational way? So they formed what's called the JNC, Joint National Committee, JNC. The JNC, in its final manifestation, back in JNC 8, I think it was, a couple years ago, had grown to about 100 different organizations. So the cardiologists, nurses, pharmacists, every kind of physician group, dietitians, everybody got together and they all looked through the literature and tried to come up with some general guidelines for how best to define what hypertension is and to treat it. And we started with JNC 1 back in the 50s. We're up to JNC 8. So 8 different committees have met over the last 50 to 60 years. And this time they skipped JNC altogether and went back to something else, and I'll talk about that in a minute. But what happened was the Joint National Committee decided, and if you look on page 198, this was their, when I made this book, and you got to realize I only made this book in November, and it's already been changed since then. So this is all old now. But anyways, let me just show you. On page 198 on the top, there's the old classification, and it was this. A normal blood pressure was anything 120 or systolic below 80 diastolic. So anything under 120 over 80 was normal. If you had a blood pressure between 120 and 120 and 139 systolic, or 80 to 89 diastolic, you were considered to be pre-hypertensive. You weren't hypertensive, but you wanted to be. Stage 1, so these patients, you notice they mentioned, no antihypertensive drug is indicated. Mostly you just want to do lifestyle changes, exercise, lose weight, quit smoking, get your cholesterol down. All those things all nurses say to their patients, and some of them work. Stage 1 hypertension was anybody 140 to 159 systolic, or 90 to 99 diastolic, and then most severe kind, stage 2 hypertension, was above 160 systolic or 100 diastolic. So that was great. Then, if you look on the bottom of page 198, in 2017, they came up with a new one. So at the end of the year, in December, around Christmas, the JNC 8 decided to appoint, rather than getting everyone to get the band back together, they just appointed a working group and decided to redefine what hypertension is. They announced this in January, so it's only been out for several weeks. And this is what they announced. And maybe I'll go on the camera. It's on the bottom of page 198. That's the new one. And I'll go on this. So this is how now everybody's classifying it. All right. Normal blood pressure. Can you see that? Normal blood pressure is anything, again, same, 120 or 80 or below. And the elevated normal blood pressure is 120 to 129 systolic and below 80 diastolic. So see, they have classification. Now, and this is the bottom of the table on page 198. But they have normal and elevated. So your systolic is 120 to 129, diastolic still below 80. We used to call that pre-hypertension. Now they just call it elevated normal, okay, the high normal. And finally, hypertension. If you're 130 to 139, 80 to 89 diastolic, that's stage 1. And if you're above 140 or 90 diastolic, that's stage 2. So that's the current, as several weeks old only, classification for hypertension that everybody's supposed to use. So I'll put this on the next test. So put a little note next to it. This is how you classify hypertension. Now, I'm going to show you if you go to page 204, let me continue, don't write. So what the JNC did, starting for the first one, or JNC 2 I think, they said, well, let's talk to America and let's see how many people are aware they have hypertension. And if they're aware, how many people are being treated. And if they're being treated, how many people are actually under control? The treatment's actually working. All right, so look on page 204 on the top. This was the JNC 2, 1976 to 1980. So how many people that had hypertension knew they had hypertension? And the awareness was 51%. So back in the 70s, only half the people who had it were aware. But there wasn't the effort there is nowadays. Every time you go to the physician's office, now they always standardly take your blood pressure. You go to the mall, they take your blood pressure. You go to the dentist, they take your blood pressure. So I mean, they're a lot more screening nowadays. So look at 88 to 91. They did the survey again. How many patients were aware at that point? 73% were aware, so that's an obviously nice jump from 50 to 75%, rounding. That's good. How many were being treated? 55%. And how many were under control? 29%. So even if you're aware of it, a lot of those patients aren't being treated, or if they are being treated, it isn't working. Their blood pressure is not under control. All right. Let's look up in the 91 to 94 next. 68% awareness, 54% treatment, 27% effective. So here's, the next 5 years or so, things are just as bad. Then from 99 to 2000 in a different survey, you can take a look. So let's jump down to JNC 8, down the bottom, page 204. JNC 8, that was 2014. They, of course, always repeat this. And they said, well, how many patients are aware? And the answer was 60%. So today, with modern medicine, you can imagine, only 60% of the people still know, are aware that they have hypertension. How many are under control? 56%. So about half, a little more than half. It's better, but it's certainly nothing to brag about, right? So what does it mean to you, practicing CRNA? Well, it means when I go to work, every day I'm going to run into someone who's hypertensive, just about. and only half those people are under control. This is now, in 2018, tomorrow when you go to work. There's not a lot of control going on here. So it's not a tremendously success story for us in medicine. Patients age 18 to 59 years old, you see it's a little bit lower than it is in oldies. I think oldies are more used to going to the doctor and taking pills. Younger people may not even be screened because they feel fine. So, the data as of now is this, on the bottom of page 204. Currently, 66 million people in the U.S. are classified as hypertensive. 39.9 meet guideline targets. Using JNC8, 56% have a controlled blood pressure. In patients 60 or above, it's better than in patients who are younger. So there you go. That's where we currently stand. Now, let's go back and look at what they've done recently. So go back and look at page 199. Now they've gone and further, so this is table 7 on the top of page 199. Prevalence of hypertension based on 2 blood pressure thresholds. They list different age groups and all that, and you can take a look at it. Also ethnicities, differences in their blood pressures and so on, and you can take a look at that as well. It's pretty pitiful either way. It's not a tremendous success, but according to the new guidelines from several weeks ago, this is what they did. Normal is considered less than 120/80. Elevated means 129/80 or less. Stage 1 is 130 or above, diastolic above 80. Stage 2 is 140 or above, diastolic above 90. Somebody with a hypertensive crisis, if the top number is over 180 or the bottom number is over 120, the patient is going to be susceptible to having a morbid event, bleeding, stroke, thromboembolism. Something could possibly happen within the next 24 hours. That's what a hypertensive crisis is. And they require immediate hospitalization, and you need to get their blood pressure down. So anytime, and I mean, you go into a PACU with a patient and take the first blood pressure when you get there, and it's not uncommon to see something pretty high. I'm sure you've all seen many times. Somebody's blood pressure is above 180 or 120. That's considered, by definition, hypertensive crisis. And then we can usually get it down, so it's not a big deal. Other changes in the new guideline, let's take a look at page 200. Only prescribe medication for stage 1 if a patient has already had some kind of event, such as cardiac disease or diabetes, kidney disease, etc. Recognize that many people will need 2 or more types of medications to control their blood pressure. So here's what happens. Patients get prescribed a blood pressure medicine, say 1, this is in the old days, and they take it, and it wasn't effective, and they developed tolerance to it, or their dose needed to be tweaked, but they never went back and got it again, and it was ineffective. The most common thing that happens is the patients don't take their medicine right. Here's the reason. They didn't feel bad when they had hypertension. Maybe they got dizzy every once in a while, they got a little woozy, they just attributed it to the fact that maybe they ate something funny, or they were, getting old or whatever. They didn't really, it was very specific. It just felt kind of funny for a while. You put them on an antihypertensive medication, and now they feel bad, because the medication's got side effects. It's making their blood pressure lower, they got CNS depression, they got all kinds of problems in their legs and claudication and so on. So what are they going to say? well, geez, I felt better before I found out I had hypertension. And then now that it's being treated, I feel awful. I'm starting taking my medications. And they stop taking their medications. So unless you get the patient on the right meds, that's a really an art, and it takes a little bit of work. Then a lot of times the patient won't stay on their medications. And what they're saying is that what they found over the years is rather than just increasing the dose of one medication to make it more effective, just add a second one instead and keep the doses lower. There'll be less side effects and the patient will be more likely to take the drug. They try to make the drugs once a day dosing. Obviously, the less times a day you have to take them, the more compliant you'll be. They'll try to make combination products, put a diuretic and a beta blocker in the same pill, because this way the patient only has to take one pill a day, all that kind of thing. So you'll see when we go through the charts, it'll be next week, all the different antihypertensives. I mean, there's page after page after page, and every combination known to man. It's not because they couldn't make up your mind which one to give, or they want to give the physicians or the NPs a lot of choices. It's that some drugs work in some patients, some don't. You got to trial and error. Some doses are better than others. Once they're on them, they develop tolerance, so you got to bump the dose up, usually after 4 to 6 weeks. So there's a lot of kind of toying around with it for these drugs. The patient's going to be on them for life, hopefully. So it's worth doing, and we're getting better at doing that. I can say Kaiser, as a national healthcare organization, is listed as having the highest rates of compliance for their hypertensive patients, highest rates of recognition and treatment and success in treating hypertension. But what they do is they have a team approach. There's a physician involved with the initial diagnosis. Then once they're involved, they turn them over to nurse practitioners who will follow them and pay attention and watch their diet and counsel them and take time. Nurses are good at that. That's what we're good at, is being patient advocates. And they'll work with them in a hypertension clinic, bring them in every 3 or 4 weeks, take their blood pressure again, tweak the medicine, change your diet, until they get the patient stabilized. So it takes that kind of a concerted effort on the part of us, the healthcare folks, in order to be successful. All right, third bullet on page 200, identifying socioeconomic status and psychosocial stresses as risk factors that should be taken into consideration. The new guidelines were developed by the American Heart Association and the American College of Cardiology and 9 other health professional organizations. They were written by a panel of 21 scientists and looking at 900 studies. So the new guidelines are the successor to the 7th JNC. And there we go. Now, on page 201, a couple of more definitions before we get into this. Hypertensive urgency, emergency, and crisis. These are 3 terms that are used quite often. They're very specific meanings in the drug world. Pharmacists use these a lot. So let's look at them. Hypertensive urgency occurs when a patient comes to medical attention with severe hypertension, systolic blood pressure above 180 or diastolic above 120, but does not have any end organ damage. The blood pressure's fine, their heart rate's fine, they're not having any eye changes, any other issues, damage to the kidneys, etc. So these patients, it's urgent to get their pressure down, but it's not an emergency. Hypertensive emergency, same thing, both hypertensive urgencies and emergencies. They have high blood pressure above 180 over 120. However, an emergency differs from an urgency in 2 respects. First, an emergency is the presence of acute organ damage. The patient's seeing eye changes, the patient's seeing kidney problems, kidneys functions getting messed up. Something's happening as a result of the high blood pressure. End organ damage is often the result of the acute rise in BP. Second, Unlike patients with an urgency, those seen in emergency require immediate therapy. So they have to be kept in the ER and given drugs right away to get their blood pressure down. And finally, a hypertensive crisis, we already mentioned, is 120 of greater than 180 over 120, and it's if it's very high, then you have to treat them immediately as well. So the next page for the hypertensive crisis, general idea is number one on page 202. There's been an abrupt increase in blood pressure. Somebody, for some reason, why? Did they ingest drugs, street drugs and so on? Did they stop taking their hypertensive agent and now they're having withdrawal symptoms? Number four, do they have they're on MAO inhibitors and they ate something that's going to make their pressure go up? Do they have pheochromocytoma, vasculitis, autonomic hyperactivity? The next page, do they have a cardiac issue that's going on, renal, neuro, OB, or post-surgical? So, in other words, if their pressure's that high, figure out why it's that high and treat it and get it down. Now, anesthesia-wise, what happened is this. When I trained back in the 1970s, when we had a patient that came to surgery with a high blood pressure, and they say, I went into pre-op, we didn't have pre-op in those days, we took patients' blood pressure when they got in the room. Let's say the blood pressure was 190 over 130, I'll just make some number up. Then, if it was an elective procedure, then we'd say, well, we better cancel the case. And we did, and we would send them off to an internist or cardiologist, whoever the appropriate family practice doctor was, and get the blood pressure treated and bring them back at another time. A lot of people said, now wait a minute, we're anesthesia. If there's one thing we're good at, among anything, it's making people's blood pressures go down. That's one of the things you can list us on the top of Mount Rushmore for causing hypotension. Everything we do causes hypotension. So why are we canceling these cases, sending them off to another provider, which they may or may not show up and go to their appointment, when we could just give them drugs and make their blood pressure go down? Why do we do that? So we did a lot of big studies back in the 80s and so on. The VA did one with over 300,000 patients, and they found out the way we currently approach it now. That first of all, the surprising thing was hypertension as a disease didn't represent a major risk factor for surgery. It was just a minor risk factor. Unless somebody's blood pressure was 250 over 150 and totally out, off the charts, they were exceptions. The average person with hypertension, even if their pressure was high, is only a minor risk factor. Number two, we can make their blood pressure go down. We got a whole drawer full of drugs, pick one, make the pressure go down. You know how to do it. It wasn't hard. Put them to sleep, control their pressure, and what our issues tended to be more often was at the end of the case, in the PEC. Because at the beginning of the case, I can give propofol, I can turn the SIVO higher, I can give fentanyl, I can give labetalol, I can, onward and onward, I can give a lot of stuff to make the pressure go down. I got control. During the case, I have control. But when you wake the patient up at the end, you don't have control anymore. You turn the gas off, they're coughing on the tube, they're shivering, there's somebody's yelling at them, move over on the bed, raise your head off the bed, they're in pain. For any number of reasons, everybody's blood pressure tends to shoot up when you wake them up. You know that, I see it every day. So you get them off to PACU, and they have hypertension. Then what do you do? So our job is to make sure that it doesn't happen. So and we'll talk about the anesthesia management, not today, but next week when we get through all this. But it takes some finesse, and we can do it, and we do it. That's the way we practice nowadays. You've done it already in your short anesthesia careers, I'm sure, and we'll talk more about it later. Okay. So let's go to here it is. Let's go to page 206. Now, the difference between JNC 7 and the current recently changed recommendation is, in JNC 7, they raised the threshold for treatment to 140, especially in elderly people. They said if you're older than 60 years old, chances are your pressure is going to be a little bit higher. That's okay for you. And let's not call these people hypertensive and let's not give them drugs, as long as their pressure was below 140. So now that what they've done in these recent recommendations in the last couple weeks is they've brought it back down to 130. So they're making it stricter. And a lot of people are saying, well, it's going to be hard to get people who weren't on medicine, now all of a sudden you want to make it go backwards and say, yes, you need to be treated. So it's a wonder, people are waiting to see how this is actually going to work. But nowadays, all the authorities say, treat a patient until their pressure is below 130, when it's been below 140 for several years. So that's the big difference between the two, and the controversy of it all. So let's take a look at page 208. 208. These are kind of the standard things. I think most nurses, certainly most cardiac nurses, could say this off the top of their heads. This is no big mystery. But what are some of the cardiac risk factors for having high blood pressure? If you've got a chronically high pressure in your pipes, something's got to give sooner or later. Normally the most common thing that happens is you get renal disease. The pressure in your kidneys is high. Chronically it causes renal problems. The second most common thing it causes is heart failure, because the heart's pumping out against that high pressure all the time, and that goes into failure. All right, now obviously stroke and there's many other blood clots can happen. But what are some of the cardiac risk factors that can be associated with hypertension? Smoking, obesity, physical inactivity, high cholesterol, dyslipidemia, diabetes, age older than 55, and family history. What are the causes? Some of the identifiable causes of hypertension: sleep apnea, drug-induced because of some medications, kidney disease, hormonal problems like aldosteronism, chronic steroid therapy, aortic problems, and thyroid problems. All can be identified as reducing hypertension. Now on the next page, this is from Framingham, page 209, and it's been updated many times over the past 50 years, but this is pretty much given. And if you have a control group with hypertension and the treatment group that's hypertension but treated successfully, look at the data. It's unbelievable. The 5-year morbidity of having some issue without treatment is 55%, and with treatment is 18%. So treatment works. Death, 19 out of 194 in this study, 8 out of 186. So we cut the death rate in half. And you'll notice all the rest of the problems are also much minimalized in the patients who are treated. So the idea is treat the hypertension and it'll be a benefit to the patient. If you look on page 210, say this finally, these are some of the lifestyle modifications we as healthcare providers are supposed to be talking to our patients about, and whether you are or not. A weight reduction, and what does that do? Well, it can lower the blood pressure, systolic anywhere from 5 to 20 beats per minute, depending on how much weight you lose. Adopting the DASH diet, the healthy cardiac diet, you can drop your pressure 8 to 14 millimeters of mercury. Sodium reduction, physical activity, moderate alcohol consumption. You should drink. You just should drink it moderately. Is what they're saying. Limit consumption of no more than 2 drinks a day, etc. And that can lower your blood pressure 2 to 4. It's not a lot, right? Okay, let's take a break. Page 216. All right, we'll get into the gory details of these drugs next week. But just for an overview, the current recommendations are that there are 5 groups of drugs used to treat hypertension. There's more, some miscellaneous niche drugs, we'll talk about those. But in general, there's 5 groups of drugs used to treat hypertension. Number 1 are the diuretics. Number 2 are the calcium channel blockers. Number 3, the ACE inhibitors. 4, angiotensin receptor blockers or ARBs. And 5, the beta blockers. Those are the drugs. I'm going to go through them here in a second. So the 5 categories are diuretics, calcium blockers, beta blockers, and then the angiotensin receptor blockers, and the angiotensin converting enzyme inhibitors. So those 5 classes. So take a look at page 216, and let's read the recommendations. These are the current approaches to hypertension. Recommendations there on the page in the box. Nearly all the recent guidelines recommend a thiazide-type diuretic, a calcium blocker, an angiotensin converting enzyme inhibitor, or an ACE inhibitor, and an angiotensin receptor blocker as initial therapy for the general population. So that's what they're currently recommending. For black patients, a thiazide-type diuretic or calcium channel blocker is recommended for initial therapy, except for those with kidney disease or heart failure. Those patients should receive an ACE inhibitor and ARB. Beta blockers are generally no longer recommended as initial sole therapy. And that's kind of new. Many physicians still prescribe them initially. So they don't really care what the recommendations say, which is fine if it works for them. But you'll still see a lot of people taking beta blockers for hypertension. Except for those patients, we have another indication for the beta blocker. Many patients with hypertension need more than one drug to control their BP. Generally, if the first drug does not achieve the goals, adding a second drug with a different mechanism of action is more effective than increasing the dose of the first drug. It allows for the use of lower, better tolerated doses of both drugs. If an ACE inhibitor or an ARB was used initially, it would be reasonable to add a diuretic calcium channel blocker. 2 renin-angiotensin system inhibitors should not be used together. When the baseline BP is greater than 20/10, more than you want it to be, that's the point at which many people add a second drug. And that's the general guidelines. Now let's go through this real quick. Diuretics are considered the first line treatment. Many physicians use those first of all classes of drugs. The reason is they're cheap. They cost less than $10 a month. In some cases less than $5 a month for the old ones. They're effective. There's minimal side effects. And so they're very popular to use for hypertension that isn't very severe. Why are the diuretics antihypertensive? What you might be saying to yourself, well, everybody knows that, they make you pee. And that's not true. The diuretics are antihypertensive because we don't know why. When you get put on a diuretic orally, chronically, You'll have diuretic effect, you run to the bathroom, maybe for the first 5 to 7 days, and then you develop tolerance. You don't have to run to the bathroom, it's just you go back to normal. Your blood pressure goes down and it stays down. So it's obviously another mechanism besides hypovolemia that's causing a drop in pressure, and nobody's really sure how, but so what? It works, and it's pretty effective. So many patients take a diuretic alone or in combination with another drug. And we'll go through that at later, next week. The next on page 217, the second category are called the angiotensin converting enzyme. The angiotensin converting enzyme is abbreviated as ACE or ACE, the ACE inhibitors. And by inhibiting the converting enzyme, we're going to look at this here in a minute, you will lower blood pressure. The third group, the ACE inhibitors, by the way, are also first-line therapy for heart failure. And the big thing they have going for them, well, let's take a look at the medical letter says. ACE inhibitors, I'm going to read it on 217, second column. ACE inhibitors are effective in treating hypertension and generally well tolerated. They're less effective in black patients and in those with low renin hypertension, unless combined with a thiazide diuretic or a calcium blocker, in which case then they're just as effective. ACE inhibitors have been shown to prolong survival in patients with heart failure or left ventricular dysfunction. So that's a real mild statement, but just think about it. If you take an ACE inhibitor and you have heart failure, you're going to live longer. That's a pretty good commercial. I could write that. Hey, take my drug, you'll live longer. A lot of people would sit up and pay attention to that, right? So it's pretty effective for that. All patients with any kind of heart failure now, it's standard to put them on an ACE inhibitor of some kind. The third type are the ARBs on page 218, angiotensin receptor blockers, and they're usually used as an alternative to ACE inhibitors. If the patient can't tolerate an ACE inhibitor, then they'll go to an ARB. Some physicians use those as first-line treatment instead of an ACE inhibitor, either way. There's one drug that's a direct renin inhibitor, and we'll talk about it next week. Next page, 219, are the calcium blockers. Calcium channel blockers are structurally and functionally heterogeneous group, and they're pretty good treatment for hypertension. And finally, the beta blockers on page 220. The beta blockers are very commonly used for hypertension, and we're going to get into those a little bit more today. But then there's some miscellaneous drugs on page 221. The alpha blockers, minipress, prazosin, and so on. We'll talk about them later. Clonidine and those types of drugs. The direct vasodilators on page 222. Hydralazine, nitroprusside, nitroglycerin. We're going to go into those in great detail. And that's kind of the end of it there. So in general then, what I'm trying to get to is there's 5 classes of drugs that are commonly used to treat hypertension. Diuretics, calcium channel blockers, beta blockers, ACE inhibitors, and ARBs, angiotensin receptor blockers. And those are the 5 common classes of drugs, and some combination of them. Patients will take 1, 2, 3, they can occasionally even be on 4 different medications for severe hypertensive episodes. Now, let me go on camera and page 211. Page 211. I'll go to the camera and point. This is a drawing of the angiotensin-renin-angiotensin system. And this is a complementary system to the autonomic nervous system. In other words, many folks, physiology people will tell you, there's three primary systems in the body to maintain blood pressure. The autonomic nervous system, catecholamines, dopamine, all that. The renin-angiotensin system, this we're going to talk about now, and vasopressin system. So the three main functions to maintain blood pressure in a human being are the autonomics, the renin-angiotensin, and the vasopressin systems. And they work hand in hand. When you have catecholamine release, we've covered this before, you cause stimulation of beta-1 receptors in the kidneys. That in turn causes renin release, and the renin release then turns this system on, the angiotensin receptor blocker system. So they're tied together, they're linked. When you stimulate one, you stimulate them all. And they all come into play. So let's take a look at this. This is angiotensin system. So I think you've had this before, but we'll do it anyway. All right, there's a precursor made in the liver, protein. It's called angiotensinogen. It's right here at the top. Angiotensinogen. And that protein's released, and it's a precursor. You act on the angiotensinogen with the hormone renin. So renin is released from the kidneys. It's a beta-1 effect, even though it's in the kidneys, not the heart. And renin then causes the conversion of angiotensinogen to angiotensin 1. Then angiotensin 1 is further converted, the next step in the pathway. Angiotensin 1 is converted to angiotensin 2 by the converting enzyme, the ACE. The angiotensin converting enzyme that converts angiotensin 1 to 2 is actually derived from the lungs. I think they're probably showing it here. So, you got angiotensinogen precursor, that's acted upon by renin. Renin converts it into angiotensin 1. Angiotensin 1 is further converted by the ACE, the angiotensin converting enzyme, into angiotensin 2. Angiotensin 2 is the active chemical protein, and that binds to angiotensin receptors and produces stimulation. You retain salt, you vasoconstrict, you retain fluid, and your blood pressure goes up. So angiotensin 2 is the active chemical, and the angiotensin 2 can work on any of the angiotensin receptors. Okay? So, if you give a drug that's an ACE inhibitor, you block the converting enzyme, angiotensin converting enzyme right here. See where my pen is? Then you block the conversion of angiotensin 1 to angiotensin 2, and therefore you reduce the levels of angiotensin 2, you interrupt the system, and you cause hypotension. You get vasodilation, you secrete salt, and both which make your pressure lower. Okay? Everybody with me so far? Now, here's the downside. It's always a downside. When you inhibit the converting enzyme, you block the conversion of 1 to 2. Right? That's what you're trying to do, right? However, you also block the breakdown of bradykinin. Bradykinin in the body is broken down by the angiotensin converting enzyme. So if you give an ACE inhibitor and block it, you're going to block the breakdown of bradykinin. bradykinin is going to accumulate and it's going to cause the patients to cough. So the number one side effect of ACE inhibitors is cough. And it sounds kind of trivial to us when we deal with life and death and all that good stuff. But for a patient taking a medication at home for the rest of their life, 15, 20, some studies say with some of them, maybe up to 25% of the patients develop a cough, they can't get rid of it, and they stop taking the drug because the drug makes them feel worse than the hypertension. And that's a problem. Now, standard therapy is, if the patient's on an ACE inhibitor and it's working, but they can't stop coughing, then switch them to an ARB. Because here's what happens. Angiotensin receptor blocker is a drug. Here's one here, is right here. That just goes to the receptor and blocks it. Classic antagonist. So the ARBs are receptor blockers. They don't mess with the converting enzyme. So that you can still break down bradykinin so you don't get a cough. So the ARBs don't cause the cough that the ACE inhibitors do. So everybody see that? So you can just give them an ARB, block the receptor directly, and be done with it. Now the ARBs are fairly expensive as compared to ACE inhibitors. That's why a lot of physicians use them as a second line therapy. Although nowadays a lot of them are going generic, so it's not as bad as it used to be. But there you go. So the two drugs that cause drop your blood pressure, hypotension, can be used to treat hypertension, classes of drugs, are the ACE inhibitors, which work by blocking the production of angiotensin II. In every physiology book in America, when you see the words angiotensin II, there's always a comma, and it says, the most potent vasoconstrictor in the body, comma. Every physiology book I've ever seen always says that statement. I don't know why. So angiotensin II is a potent vasoconstrictor, means your blood pressure goes up, and if you block it, then it causes hypotension. If you don't want to do it that way, you can just give an angiotensin receptor blocker directly, and it will drop blood pressure. That's two ways to mess with the angiotensin system, renin-angiotensin system. Now, there's a third way, aliskiren, which we'll talk about next week. There is a drug that messes with renin. It's an inhibitor of renin receptors. There's one drug available, and it's really expensive, not used too often, but it is around. So there's actually three ways pharmacologically to mess with this system. Yes?
Does the angioedema associated with the ACE inhibitors, is that also related to the bradykinin?
No, it's a secondary. The question is angioedema, which can be a life-threatening problem with these. Is it related to bradykinin? The answer is probably not. It's just something that happens in some patients. Now, if you take a look at the table in the medical letter, and that's on page 218. And they're listing on the top, the angiotensin converting enzyme inhibitors. I'm on page 218. And you notice by agreement for the USP, they're all end with PRIL. So when you see a patient on a PRIL drug, that's an ACE inhibitor. These drugs you see on a daily basis almost. Captopril, enalapril, lisinopril, very common. Lisinopril, probably the most widely prescribed of them, and all the rest of them as well. There are lots of ACE inhibitors. And they're all Me Too drugs. They all do the same thing. There you go. Below that on page 218 are the angiotensin receptor blockers, the other classification. And as you can see, they're all named with ARTAN at the end. So it's candesartan and losartan, valsartan, etc. They all have a similar generic name. And those are the angiotensin receptor blockers. There's a bunch of those too. If you look at the prices, this is the pharmacy 30-day cost. You can see the ACE inhibitors tend to be cheaper. They've been around longer. The ARBs, the prices tend to be higher, so they don't usually use those too often as first line. They just use them in people who cough too much from the ACE inhibitors. Okay, now if you can look at the bottom of this page, since we're on it, 218, there's a renin inhibitor. So, Aliskiren, Tecturna is the name of it. It's on the bottom of the page 218 on the table. It's a direct renin inhibitor. And it's right up is right there. It's an FDA approved alone or in combination with other drugs for the treatment of hypertension. Whether it offers an advantage over the ACE inhibitors or ARBs remains to be determined. Not enough people are on it to really see if it works well enough or not. But you can see the monthly cost is pretty high, $115 for one pill. So you can give Phenazepam for $3.60. So pick one. You know.
Does that also cause the cough that ACE inhibitors?
No,
No?
not the renin. Now, lastly, these drugs, all the angiotensin effective drugs, ACE inhibitors, ARBs, and Aliskiren, are all contraindicated in pregnant patients, women. They all cause birth defects. It's a very prominent, well-known effect, and so you have to not give them to pregnant women.
Which one?
ACE inhibitors and the ARBs. Okay, let me wrap it up there, and we'll pick it up here next week. And good luck on your test, and I'll see you next week.